Hello everyone, welcome to the second part of acute rheumatic fever. We are looking into clinical manifestation of acute rheumatic fever now. After considering the Jones criteria, where we divided the clinical manifestations of acute rheumatic fever in two parts, that is the major and the minor manifestation, and also we have seen its application and how to apply rheumatic fever through Jones criteria. Let us look into how this clinical manifestation appears over the period of time. As this graph clearly shows that the earlier symptoms of acute rheumatic fever would be associated with polyarthritis, carditis, and erythema marginatum, whereas development of chorea requires a much longer time and its duration is also quite long, and subcutaneous nodule even appears later, that is approximately between 2 to 3 months. Arthritis. Arthritis is seen in approximately 75% of patients with acute rheumatic fever, and it is one of the earliest manifestations that can be seen. It correlates temporarily with peak anti-streptococcal antibody titer, typically involves larger joints like knee, ankle, wrist, and elbow, in that order only. Is the most affected one is the knee joint, whereas the least affected one is the elbow joint. Rheumatic joints are generally hot, red, swollen, and exquisitely tender to touch. You can consider some homeopathic medicines here, like such type of tenderness is seen in hepar. Also, joint involvement is characteristically migratory in nature. It is from one joint to other, a shifting type of uh, symptoms of arthalgia. Dramatic response to salicylate can be seen. Typically, this arthritis is not deforming, as we see in cases of rheumatoid arthritis, where deformity is quite common. An inverse relationship between the severity of arthritis and the severity of cardiac involvement is seen. So, there is, if arthritis is present, then there are a great percentage of chance that even the cardiac involvement might also be seen. Jacquard's arthritis is a progressive deforming arthropathy of hands and feet in young adults following recurrent rheumatic fever or systemic lupus erythematosus. So we have a term used, that is Jacquard's arthritis, for arthritis developing after acute rheumatic fever. Now we have some features of rheumatic arthritis, and we have divided in, we classified it as, or we have used the mnemonic of ABCDEFG. A stands for asymmetric, acute, painful polyarthritis. B stands for where the bone structure is normal and after recovery no residual damage can be seen, which is common in children with complete recovery. D stands for dramatic response to salicylates. E stands for early manifestation of rheumatic fever. F stands for fleeting polyarthritis, that is shifting. The pain will, or the joint will shift from one joint to other. And G stands for good prognosis, that is eventually it will heal and not cause any further complications. Also, IJKLM is also used. That is involves a larger joint, especially knee, ankle, elbow, and wrist. Joints are red, swollen, and tender for a day or a week. Knee joint is most commonly involved. L stands for large joints are involved, and M stands for migratory polyarthritis. It is same as that of uh, F, that is fleeting polyarthritis. We have migratory polyarthritis. Now, let us consider carditis. Carditis is seen in around 50 to 60% of patients with acute rheumatic fever. Carditis, as a resultant chronic rheumatic heart disease, are the most serious manifestation of acute rheumatic fever, which is characterized by pancarditis, and is almost involving the whole heart. Endocarditis, vulvitis, is a universal finding. Mitral valve is the most commonly affected, followed by aortic and tricuspid valve in that order. So, if you remember, we have seen the valvular heart disease. One of the etiology of development of valvular heart disease was rheumatic fever. We also see valvular insufficiency in both acute and convalescent stage of acute rheumatic fever. Convalescence is the recovering stage, where valvular stenosis usually appears several years or even decades after the acute illness. And it is very interesting because here establishing the history of the patient becomes very difficult. That to remember that the person suffered from recurrent sore throat or episode or two of sore throat, and after decades of that episode, a person is observing carditis. It's very rare. Now, the symptoms of carditis: dyspnea would be present, syncope and pain due to pericarditis may be present. Endocarditis and pansystolic murmur of mitral regurgitation and early diagnostic murmur of aortic regurgitations are the signs. So, we have two types of murmur. That is pansystolic murmur and early diastolic murmur. Myocarditis, if present, it will present with cardiomegaly, an increase in the size. Tachycardia, disproportionate to fever. Tachycardia would be high as compared to the temperature reading. Temperature reading here stands out to be low. The tachycardia is proportionately quite high. Also, unexplained congestive cardiac failure carries calm murmur, which is typically delayed diastolic murmur due to mitral valve involvement. S3 gallop is a type of sound due to cardiac failure. S1, the first heart sound is muffled or soft due to conduction defect. Erythema and heart blockage may also be present. Pericarditis will present as chest pain, pericardial friction rub, and pericardial effusion. It stands out. We don't have reasons for the development. Yes, it is present. Here you can see there is enlargement of the size. This is an acute carditis X-ray of an 8-year-old patient. Now, understanding the pathology for development of cardiac symptoms, and we can assign those symptoms to a singular body, that is Eshkov body in the atrial myocardium, is the most characteristic feature of acute rheumatic fever. Left-sided valves are commonly involved due to greater strain on these valves. Initially, there is mitral regurgitation, which is later followed by fibrosis of the valve, leading to mitral stenosis. So, Eshkov body in the atria, muscles of the atria, left-sided valves are involved, completely involved with both. Initially, it will develop with mitral regurgitation, later on develop into stenosis also. Also, there is Macallum's patch, is seen in the posterior wall of left atrium above the mitral valve. Often this form is a nidus for infective endocarditis. These are certain names that we should remember. It is quite interestingly important for your Viva also. What is a Macallum's patch? So it's a complication of acute rheumatic fever, which is a nidus or the place of origin for infective endocarditis. Also, rheumatic vegetation are small beaded vegetation like warty or a wart-like growth due to aggregation of platelet thrombi. It is seen along the line of valve closure. Surface exposed to forward flow is affected. So it will be present on the top layer of the valve. Adherence of leaflet at the commissure, so the point where the leaflets are coming in contact, it will stick together. Verruca also seen in quadrilaterally. Verrucas are actually viral growth or the other name used for warts. Valvulitis may resolve without deformity or may undergo fibrotic scarring, eventually leading into stenosis. And this is how the Ashcroft body looks like in microscopically. We have some other pictures also for Ashcroft body in high magnification. Now we'll see the sequel of carditis. Now, what happens when the acute carditis or the acute symptoms of carditis stays there a very pretty long period of time? So the valvular involvement in rheumatic heart disease leads into involvement of mitral valve, which is the most common valve involved in rheumatic heart disease. Also, cases are noted with aortic valve involvement, that is, the left side would be involved more as compared to the um, right side. Also, aortic valve involvement along with mitral valve involvement is around 20 to 25%. But isolated aortic valve involvement is only 5 to 8%, where mitral valve won't be involved. Also, tricuspid valve involvement and pulmonary valve involvement are having a very low percentage of involvement. Obviously, the major one is the left-sided valves. What about the mitral stenosis, that is the left-sided valve? Mitral stenosis takes longer duration to develop after an attack of acute rheumatic fever. This stenosis will eventually develop as a result of fibrosing of mitral ring, commissural adhesion. So initially, it will develop as a regurgitation followed by stenosis. So that is the reason stenosis requires greater amount of time. Contracture of valve leaflet, condy, tending, and papillary muscles. We see contractures or pulling of the structure. Dyspnea with or without exertion is the most common symptom in older children. Orthopnea, nocturnal dyspnea, and palpitation is present in more severe cases. Opening snap, low-pitched rumbling mitral diastolic murmur with pre-systolic accentuation ending in loud first sound. Opening snap. What is opening snap? We know that the heart sound produced, the first and second heart sound produced, are due to the closing of the valve. But here, before the first heart sound, we hear an opening snap sound, which is low-pitched mitral diastolic murmur with pre-systolic accentuation ending in loud first sound. So it happens the first sound would get exaggerated with opening sound, which is a low pitch sound. What about the metal regurgitation? It is one of the most common valvular involvement in children with rheumatic heart disease, and it is the early manifestation also. The mitral valve leaflet is shortened because of fibrosis, resulting in regurgitation. Usually, patients are asymptomatic with mild regurgitation. Rarely, fatigue and palpitation may develop. Palpitations are due to atrial fibrillation. The hallmark of mitral regurgitation is a regurgitant systolic murmur starting with S1, grade 2 to 4-6 at the apex, with good transmission to the left axilla, best demonstrated in left decubitus position. And this is a remark about the position used for listening to the sound. Short, low frequency diastolic rumble may be present at the apex. The S2 may split widely as a result of shortening of the left ventricular ejection and early closure of aortic valve. The S3 is commonly present and is loud. Now, after the mitral involvement, let us look into the aortic insufficiency. What are the symptoms produced by the aorta? Sclerosis of aortic valve, distortion and retraction of the cup, characteristic cardiac murmur, early diastolic murmur, an apical presystolic murmur. There is an Austin Flint murmur is usually seen. After the carditis or the symptoms of heart, now we have chorea. You can see in this picture, it's a boy which is see. It seems like this boy is dancing. This is actually not dancing. These are the neurological symptoms produced by acute rheumatic fever. Let us look into the chorea. Chorea is seen in around 10 to 15% of patients with acute rheumatic fever, where the latent period is 3 to 6 months. This is also known as Sydenham chorea or St. Vitus dance. It is a neuropsychiatric disorder where the neurological signs are choric movement and hypotonia. So what happens is when the person tries to walk normally or is trying to do some act, due to uncoordinated movement, there is a difference in the movement of both the extremities and even other musculatures. And due to hypotonia, there is a wavy-like movement that seems like the person is dancing. Also, some psychiatric signs like emotional liability, poor school performance, hyperactivity, separation anxiety, obsession, and compulsions may be seen, exacerbated by stress and disappears with sleep. So, if the person is more stressful, you'll see the dance to be rock and roll. But if the person is sleeping and is in the calm position, we might not see such type of movements. Clinical maneuver to elicit features of chorea include demonstration of milkmaid's grip, it's with the weak grip, spooning and pronation of hand when the patient arms are extended. So it's a particular position of spooning and pronation. We have seen in anatomy about that. Vornian darting movement of the tongue upon protrusion. So it's a typical appearance of the tongue. It is a protruded tongue which is quite flattened and having no control on the movement. Also, examination of handwriting to evaluate the fine motor involvement should be done. Whether how much fine motor activities have been affected, and obviously in such type we see due to the hypotonia there is a defect in the even in the handwriting also. Such type of chorea is very common in prepubertal girls. It is between the age of 8 to 12. It is usually self-limiting, which lasts for around 2 to 6 weeks, and spontaneous recovery may occur in few months. It might rarely lead to, so it's not that it would be creating morbidity for a very long period of time. It is so short-lived one. In rare cases, it might cause permanent neurological changes. Next in series is erythema marginatum. It's a manifestation on skin and how this manifestation looks like. If you can see these pictures, you can see here, this is the lesion, the red color lesions, because in the name it is erythema, and marginatum with fixed margins. And you can see here, this is erythema marginatum. This is an early manifestation and it's very rarely found with characteristics of rash of rheumatic fever. Erythematous serpingeous macular lesion with pale center and the boundaries would be much clearer. Not pleuritic, hence itching might be absent. Occurs primarily on the trunk and extremities, and it is accentuated by warming of the skin. So it will be more clear if the skin is in a warm position. For remembering it, we have this mnemonic of site, SITE, serpingeous margins, itching will be absent, trunk is the main site, and evanescent and it is early manifestation might be seen. Next in series is subcutaneous nodule. So you can see here some nodules, this one, and even this, this prominence can be seen. So these are all subcutaneous nodules. Then you can see this nodules here. Presence of subcutaneous nodule is a very rare finding and it's a very late manifestation of acute rheumatic fever. With more than 95% association with severe carditis. If subcutaneous nodules are present, then in approx 95 or more than 95% of cases, you will find carditis associated. They are small, firm, non-tender nodules. We don't have any pain in them. Along the extensor surface of tendon, near bony prominences. Other sites might be behind the ear, occipital region, spine, and they appear in crops. You can see multiple nodules in a single region. And obviously, their biopsy will reveal Ashcroft bodies. So this is Ashcroft bodies are finding in the myocardium of heart and also in the nodules present. These all were the major manifestation. Let us look into the minor manifestation. Clinically, arthalgia is present. Is the absence of polyarthritis in the as a major criteria. We will also have fever, which is typically more than 102 Fahrenheit. In laboratory finding, ESR and C-reactive protein are quite elevated. We also have a PR, prolonged PR interval, which is an earliest sign of conduction block. We'll continue discussing more about acute rheumatic fever in the third and the last part. Please go through the major and the minor manifestation and how they appear, what impact do they have,